The 2024 American Urological Association's annual meeting is the premier global gathering of the best and the brightest in the field of urology. As the annual meeting highlights groundbreaking research and cutting-edge technology, today AUA TV showcases all the ways the AUA is fostering members' insatiable search for excellence.
This is AUA TV.
Welcome back to this thrilling third day together in Texas. I'm Autria Godfrey, your host. From global academic exchanges to research grants and awards, the AUA offers steadfast support to those engaging in research that's shaping the field of urology. Today, we ask, is there a place for AI in urologic care?
I see AI as an opportunity for us to enhance patient care. There is wide variability in terms of the performance of surgeons. And can we narrow that performance gap? Yes, I think so, and I think AI can play that role.
We sit down with one expert to hear how it's already being utilized and the best practices for making machine learning a part of your protocol.
The LEAD award was really kind of the gateway for me to connect with thought leaders in urology, and in turn that's forged new research collaborations as well as strong kind of career mentor relationships.
Plus, when it comes to groundbreaking research, these two are leading the way. We're introducing you to two award winners at AUA this year. And we close out our circuit of the institutions and organizations leading the way in urologic research, treatment, and care. It's an exciting third day ahead on AUA TV and a number of ways for you to view. You can always find the latest AUA TV episodes playing on the TVs throughout the convention center, on the in-house channels at several of our partner hotels, on the shuttle buses to and from the convention center, on the homepage of the AUA meeting website, and on our YouTube and X pages. We start things off with one of the most anticipated components of the meeting, the annual unveiling of the AUA's Guidelines. The AUA's clinical practice guidelines provide evidence-based guidance with an explicit clinical scope and purpose. These provide urology professionals with the best in peer-reviewed treatment recommendations and research updates. Let's find out what's new this year.
I think there's really no better way to disseminate real evidence-based science than through AUA guidelines. That dissemination and implementation is such a huge problem in medicine, and to have an expert multidisciplinary group be able to come together, distill that evidence down to what we really feel makes the biggest difference, and then interpret that in a way that says, okay, this is what we think is the standard of care at this point.
Guidelines at the AUA are dependent on evidence, and as you know, evidence keeps on changing. So the AUA guidelines have a process where every 1 to 3 years, every guideline gets an amendment.
This is a brand new literature review from 2013 to 2023. All new content reviewing the most up-to-date literature on the diagnosis and management of overactive bladder. What's really new about this guideline is our focus. We are focusing on shared decision making. This puts the patient at the center of decisions. And the reason we did that is because overactive bladder is a preference-centered treatment. We've also included data on all genders. Previous iterations of the guideline only included literature on women, and so we've been much more inclusive. Another new addition to the guideline is grouping treatments by invasiveness. Things are grouped in terms of behavioral therapy, minimally invasive therapy, more invasive therapy, to be able to present it to patients in a more cohesive way, not implying that one is better than the other. It just allows you to present it more factually to patients.
So there were a couple of changes in medical therapy. So low-dose tadalafil along with alpha blockers is now a reasonable management strategy. We used to say do not do that. Other changes, there was a change to removing transurethral microwave therapy and transurethral needle ablation statements from the guidelines. We now call those legacy technologies.
These guidelines are addressing which patients need treatment and when, and how to incorporate molecular imaging like PSMA PET into this disease setting. They're really important, really common questions that come up in the clinic, and that's where this guideline is trying to speak to, and I think provides really clear statements.
I rely on guidelines heavily. They need to be pragmatic, they need to be useful. So I rely on them heavily. I share them with my patients, but I think also insurance companies and insurers use these guidelines to change what is covered for patients. I think these are integral to the care and coverage of all of our patients. So I think they are the cornerstone of management of urological conditions.
Turning to technology, from diagnosing urological cancers to predicting patient outcomes, the use of artificial intelligence within the field of urology is becoming more commonplace by the day, like it or not. Here to discuss the pros and the cons is Dr. Andrew Hung. Pleasure to have you joining us today.
Thanks for having me.
Let's get started. Can you kind of boil down some of the ways that AI or machine learning can be used by urologists?
Sure. From diagnosing cancers or urologic conditions to treating them, to after treatment figuring out how to manage patients and predict, let's say, recurrence of disease. Those are all areas ripe for AI to play a role.
So there are a myriad of ways.
Absolutely.
There are some concerns. Can we place our full trust in AI? What do you say?
I would say not yet.
Okay.
Today, there's not a lot of AI used in clinical practice yet, but I think there's big changes that are going to happen where there are going to be specific areas where physicians can utilize AI to enhance how they do care. It's not going to happen overnight, and it's not going to be for every area of urology, for instance. It's going to be in select areas where it can enhance how physicians treat, how we take care of problems, how we engage with our patients, and how we manage diseases. And it's something that's going to have to be done very carefully. We're still going to have to use the scientific rigor that we do with any new technology that we adopt. But there will be areas where AI will be a part of patient care.
You touched on this a minute ago, but are there varying levels of reliability with AI when it comes to where you might want to implement it within your practice?
Yeah, when you train models, it's going to give you a sense of the performance of how the models perform. And depending on what the data set is that you're looking at, depending on what the modality, for instance, is it radiology, is it pathology, is it MRIs or CT scans, and what exactly is the clinical question you're looking at, the performances of these models, they vary greatly. And how well are they tested? Are they tested in an environment where it's at a singular hospital and it only works for one patient, or is it across many different hospitals, across different continents, and so forth? And so there is tremendous variability in how robust these models have been vetted.
Okay.
And really, we're looking for the best. We're looking for models that will not only assess well for patients at a given hospital, but really will assess any patient across the board. So, that's remains to be seen in many areas, but that's the rigor that has to happen to ensure that these models are actually safe and ready for clinical use.
So as a physician, what excites you the most about the future of AI?
I see AI as an opportunity for us to enhance patient care. Physicians are humans. We are all humans. We do make mistakes. Take, for instance, surgical performance. There is wide variability in terms of the performance of surgeons. And can we narrow that performance gap? Yes, I think so. And I think AI can play that role. So it's not going to replace surgeons, for instance, but it may help us elevate all surgeons so that we all perform at a higher standard.
There was a recent article published by NIH that essentially says AI is here to stay, like it or not. And it alluded to the fact that for physicians that are hesitant and reluctant to implement AI in their practice, they're going to end up falling behind. What do you say to that?
I would say that AI is a technology to stay, whether we like it or not, and it behooves us to understand, what are its strengths, what are its capabilities, but also understand what their limitations are and understand where humans will always still play a role and really just understanding how it fits into that ecosystem. So I don't think physicians are going to get lost and we're going to keep our jobs.
Wonderful. Well, Dr. Hung, thank you so much for your expertise today and for
Thanks
your time.
Thanks for having me.
We head west now to highlight two California universities. First up, the UC San Diego Men's Health Center, where they are dedicated to the unique needs of men. Let's see how they provide first-class care for both the patients and their families.
The idea behind the Men's Health Center is really to match the efforts of the women's health movement. We know that in general, men don't like to see doctors, and we're a little bit behind in getting our health care compared to women. So having a men's health center or men's health program, we have dedicated specialists that's really there really to address their reproductive health needs and also hopefully help them age better.
I have a clinical and research interest in testicular cancer, also known as germ cell tumors. In the clinic, really excited that we see all new patients with newly diagnosed germ cell tumors in a multidisciplinary context.
Our goal really here at the Men's Health Center is to create a welcoming, inclusive environment and space for patients to come and talk about these issues and really address them head on. One of the things that we really try to do are provide educational opportunities, support groups, advocacy for our patients. We're thrilled to partner with the Testis Cancer Awareness Foundation to host a patient and caregiver facing summit here in San Diego in the fall.
Now to Dr. Liao's laboratory at the Stanford University School of Medicine. Through an innovative research program that focuses on precision diagnostics and the development of optical imaging technologies, they are training the next generation of clinical urology professionals.
The Department of Urology at Stanford has a culture of innovation, collaboration, and inclusiveness. We have outstanding leadership who leads by example and who is open-minded and supportive. We are a group of passionate and diverse faculty, trainees, and administrators who are just very passionate about taking care of patients, pushing the boundary of research and innovation, as well as training the next generation of urologists and scientists. The future of this department is boundless. We really have the best people. We are ideally located. We're really at the hub of innovation and translation, and through some of the institutional programs we have, we aim to translate our discoveries and findings so that it can actually benefit patients directly.
For the past 3 years, the Leadership in Education, Achievement, and Diversity, or LEAD program, has supported urology residents from racial and ethnic backgrounds who are underrepresented in urologic research. LEAD Award recipient Dr. Samantha Thorogood and Dr. Larissa Rodriguez from the award review panel join us now in studio with more, and it is a pleasure to have you both with us today.
Thank you for having us.
Absolutely. Dr. Rodriguez, I want to get started with you because you are this year's Victor Patano Award recipient. Recognized for your research. First off, how does it feel to be recognized by your peers?
It's really exciting. I'm grateful, extremely grateful to the AUA as well as my peers. But it's really kind of an honor to feel recognized by my peers. I've been in this field for almost 30 years, so it really feels very special.
And let's talk a little bit about the research that you were awarded for. It's into urinary incontinence, correct?
Yes, I do research in pelvic floor disorders. I have had a basic science kind of research career as well as some clinical research, but I have been a surgeon scientist for most of my career, NIH funded, and my research has spanned different areas from models, animal models, developing animal models of stress urinary incontinence, cell-based therapies for stress incontinence. I'm currently working a lot on the effects of stress on lower urinary tract symptoms and as well as bladder pain, and I've done some clinical research as well.
Wonderful. All right, Dr. Thorogood, our LEAD Award winner, how does it feel to be recognized for your work?
It feels amazing. It feels like a great opportunity to kind of be recognized for the potential that I have as a very, very early career investigator.
And let's talk about your research. What can you tell us?
So my award was in support of a project that's really a multi-center prospective registry of patients who are undergoing placement of an inflatable penile prosthesis. This project was designed under the strong mentorship of John Mulhall from Memorial Sloan Kettering. And our ultimate goal is to identify factors that may be predictive of extreme satisfaction and extreme dissatisfaction in this patient population, because implanters are well aware of the fact that patient satisfaction is really contingent on patient selection and early expectation setting in this population who often has a number of comorbidities and social difficulties as well.
Fascinating. What has being a part of the LEAD program provided for you professionally?
Yeah, the LEAD Award was really kind of the gateway for me to connect with thought leaders in urology, and in turn that's forged new research collaborations as well as strong kind of career mentor relationships. And as somebody who's just starting out and making decisions about where I want to practice and how I want to structure my future, that has been hugely important. My participation in things like the Early Career Investigator Workshop and the U-Smart Academy have also helped demystify the world of NIH funding, which can be very intimidating, but it's really broken it down and made it a lot more accessible for someone who doesn't have, a background in that longstanding.
Right. Dr. Rodriguez, you are a part of the lead program review panel when it comes to doling out awards. We should point out you are new to that role. You didn't have a hand in, Dr. Thorogood's award at all, but what do you look for when you're determining which research should be highlighted?
So yes, I started the role this year, and as you mentioned, way after Samantha got her award. We really look for applicants that have a good research idea, that is well developed in their research proposal, that have a good mentor or that we feel are going to be supported. Because as a resident, as a young investigator, you really need that support to be able to be successful. So we're looking for that development aspect, an interest from an institution for the awardee as well, to ensure that they're going to be successful in their path. And we want research that is innovative, but really that has some incremental contribution to the care of urologic patients.
Right. Mm-hmm. Final question for you both. For someone who might be interested in the LEAD program, might want to, try to apply, what is your advice?
I would say the first thing is to put yourself out there. I've learned that there are a number of people in our field who are not only extremely brilliant, but extremely generous and willing to donate their time and really pass on their wisdom in order to help new talent succeed and to advance the field. So I would say to get over any fear of imposter syndrome or intimidation and really just take that first step to seek out a mentor.
Great advice. And for you?
I would say the same. I think people don't know if they like something until they try it. So I think the LEAD program for a lot of people could be an introductory kind of program for them to see if research is for them. And even if it's not that particular project they're doing on LEAD, it might be a different part of research. But I think one of the biggest assets of the program is the connections, is the educational, the access to the educational aspects that AUA and the Office of Research has to offer, the connection to mentors nationally, and really that exposure to the whole field.
So go for it.
Go for it.
All right. Well, thank you both for your time today. And again, congratulations to each of you for your award. Thank you so much. The urology department at the Mayo Clinic, Arizona, stands at the forefront of diagnosing and treating conditions affecting both male and female urinary tract, as well as the male reproductive system. From combating cancer to restoring fertility, addressing kidney stones to managing incontinence, Mayo Clinic's urology experts provide comprehensive care that improves patient lives.
At Mayo Clinic in Arizona, our goal and our vision is simple: to provide Category 1 care to patients. We do this by endeavoring to make the needs of the patient our first and only priority. We've got a dedicated staff and trainees committed to this goal, and it's a shared culture that makes it a special place for patients in their journey for cure.
We provide the best possible clinical care to our patients, and we have the best technology in the operating room to provide the best possible care. We always have a bunch of trials going on and multiple research projects to not only provide good care now, but long-term care for our patients. And in education, our trainees work right alongside me to provide the best care possible.
We're dedicated to our 3 shields. The clinical shield to provide the best possible clinical care for our patients, the research shield to provide cutting-edge and novel therapies, and the education shield to train future surgeons to provide the best care for our patients into the future.
The Neurogenic Bladder Research Group at the University of Michigan brings awareness to neurologic conditions that affect bladder function. Take a look at how they seek better care and understanding of bladder function based on the individual neurologic condition.
The Neurogenic Bladder Research Group is really a collaboration of multiple different institutions and people, all with the goal of bettering the care for people with a neurogenic bladder. And we really sat down and said, well, we can make a difference in this by trying to form a group of looking at this collaboratively, and that was the nucleus of the Neurogenic Bladder Research Group.
We are a research organization, so our primary goal is looking at generating patient-centered, relevant research in the field of neurogenic lower urinary tract dysfunction.
I think one of the strengths of Enbridge is really the individual members both bringing their individual perspective, but their willingness to collaborate and to discuss. The journey of us being able to discuss and work together is really, I think, what makes the process move forward with it. And it's just so vital to kind of both the future of the group and then also kind of the work that we do.
Now to our final day of AUA's Scientific Spotlight. New this year, P2s. These paradigm-shifting, practice-changing clinical trials in urology are designed to showcase the exceptional, groundbreaking studies that are expected to change the day-to-day practice of urology. AUA TV is thrilled to bring you P2s and clinical trials currently in progress.
So the partial trial is a randomized control trial comparing a newer way of doing radical prostatectomy where we're preserving some of the more native structures such as the fascia overlying the prostate. So it's been called the hood technique. It's also been called the Retsia sparing technique, and it was first described about a decade ago, and it's been adopted, but we don't know the long-term differences of patient recovery in terms of continence, regaining sexual function, or cancer control. So we're doing a randomized trial at multiple centers to answer that question with the primary endpoint of cancer control. We're all here to learn new things, and the Learning Lab this year is I think, a new platform. So I'm excited to highlight our work, and I think it's hopefully an opportunity for young investigators, those who aspire to do clinical trials, to learn some of the challenges and how to navigate to try to make some of these things happen so that one can make a contribution to the field. Absolutely. So I think in surgery, oftentimes we do things because we're taught a certain way by our teachers, or there's dogma, there's not really a whole lot of evidence. And I hope that by doing a randomized trial with partners at Johns Hopkins, at Georgetown, as well as Northwestern, that we can really define the way that we should be doing radical prostatectomies moving forward to benefit our patients.
Our study looked at men with BPH and OAB, and looked at treatment with the beta-3 agonist Vibegron and resolving their OAB symptoms, which persisted after treatment for their bladder outlet obstruction. The idea here with this particular medication, Vibegron, it's a once-a-day pill. It's a fixed dose at 75 milligrams without any titration. There's no hypertension warning in the label, which is good because it's a beta-3 agonist and people are concerned about that. There's no drug-drug interaction. It doesn't work. It's not metabolized in the liver by 2D6. And it's a nice crushable pill for those patients that come into the office and can't swallow one. So you sort of now have a good medication, a very good medication, which fits in a drug class which is now being recognized to resolve the real bothersome symptoms. Someone has decreased flow, incomplete emptying, all the problems of obstruction. You treat them pharmacologically or surgically. Now they still have frequency and urgency. They're getting up at night, and they may even lose urine from urgent incontinence on the way to the bathroom. So now you have medication to treat it because nobody comes back happy after treatment for their outlet obstruction, medically or surgically, if they still have OAB symptoms. I think it's important that we have a large armamentarium. This is the pharmacologic treatment. There are behavioral things that you can do. There are pharmacological things that you can do. There are minimally invasive OAB treatments that you can do. So in the pharmaceutical arena there, I think that we have really good data on 1,000 patients randomized and given treatment versus placebo, and seeing these patients improve in all 6, the 2 primary and the 4 secondary outcome variables, as early as 2 weeks.
Serving the local community of Southern West Virginia, the Charleston Area Medical Center Department of Urologic Oncology takes pride in providing state-of-the-art treatments that remove the need for out-of-state travel.
We're able to offer state-of-the-art treatment across the full spectrum of urology here, to bring the resources that we need to keep up with changing technology.
Basically, anything that can be offered at any facility, large or small across the country, we're able to offer it here at our facility.
Our residents have a team approach. They all work together to get the job done. They have a lot of responsibilities. The residency program started in 2006, and since then we've had 3 of our residents go on to do GU Oncology fellowship, and now all 3 of those guys, including myself, have come back here. And so we give you a wealth of knowledge in the GU Oncology arena.
Well, I'm proud that we actually had doctors come through our program, make major contributions for patient care in this part of the country.
This program has been built on serving the people of West Virginia, and you feel that every day. It's part of our underlining culture. The infrastructure has been built here, the financial investment has been made so that every state-of-the-art treatment is available to this community.
The Department of Urology at the Jacobs School of Medicine at the University of Buffalo harnesses an array of subspecialties to deliver a truly multidisciplinary approach, shaping and sharing the very latest best practices in urology.
The Department of Urology at the Jacobs School of Medicine, University of Buffalo, is a very large department having over 60 faculty members. We have over 110,000 unique patients we see every year, 30,000 new patients every year. What does that do? That results in an incredibly large clinical volume. This gives them an ample opportunity to do research, lots of research. We have so much data because we were one of the first programs in the country to go electronic.
Our team, over the past several years, has expanded in an incredible way under the leadership of Dr. Shevely, such that our department now represents every subspecialty within urology.
We are affiliated strongly with one of the largest private practice groups in the country. We do not compete with this group. In fact, we are intertwined with them. They're a critical part of what makes us so successful. That's frankly our secret sauce.
As we wrap up an incredible week here in San Antonio, we wanted to check in with you. What's been most impactful to you this week? Take a listen.
This week it was a little overwhelming at first because it's just such a big facility and seeing all the people. But getting into the product room and kind of networking with the different vendors, that was definitely my best part.
I saw really amazing and outstanding conferences about the AI and their applications in robotic surgery and urology. So for me, is a really innovation in the field. It will take more shape in the future, so it's really interesting.
It's gone great. I really enjoyed my time here. This morning we were able to present our work with my colleagues, and I'm just really proud of our group and that we were able to show what APPs can do, running independent procedure clinics and functioning at the top of our licensure.
So networking with everyone, seeing some of the old fellows that we worked with previously, and then just learning, gaining knowledge on like just new, upcoming, procedures, meds, all the different things that, we kind of learn here at AUA.
The week has gone amazing, and one of the biggest highlights for me has been how AUA has expanded its advanced practice provider program. So instead of 1 day, it's now 2 days. And instead of you having to go off on your own, you can network there with sponsored lunches and things. So it's incredible how AUA has now emphasized the importance of the advanced practice providers by offering a 2-day session and offering us opportunities to connect.
Sounds like it's been a successful week for everyone. Well, with that, AUA TV 2024 comes to a close. It's been a fascinating week of science, networking, and education. And if you would like to view any of the segments from this past week, AUA TV is always on our YouTube channel and X platform. Thanks for your time and attention this week. We hope you've enjoyed all of the content. And from all of us at AUA TV, we hope to see you again next year in Las Vegas. Safe travels, everyone.